This is the last in a series of presentations on radiography of the skull in veterinary patients. The intent of this last presentation is to provide case-based practice to help you identify abnormalities of the skull and apply the knowledge you've learned to determine a diagnosis or develop a prioritized differential list. Although I'm not going to spend too much time reviewing each study in this presentation, remember that you should be practicing review of studies by using the checklist provided in the initial presentation so that you consistently review the entire image each time until it becomes second nature. Be sure to always practice writing findings being as descriptive as possible using anatomic and radiographic terms before you come to your conclusions. This first case is an 8-year-old neutered male golden retriever who has several weeks of reverse sneezing with some nasal discharge. Our lateral view is slightly rotated, and notice that the patient has an endotracheal tube in place, keeping in mind that generally inhalant anesthesia or injectable general anesthesia is going to be what we want in our small animal patients for proper positioning. The image on the right is the ventrodorsal open mouth view. Unfortunately, on this image, the endotracheal tube is superimposed over the maxilla. It has not been pulled out of the way along with the mandible. So as we've seen in our presentations, the view on the right is actually one of the most important views when we're looking at nasal passages with a history of reverse sneezing and discharge. That would be my first area of interest. And on this patient, I see that there is this kind of diffuse soft tissue opacity within the right nasal passage. In the mid to caudal nasal passage, it looks a little bit more uniform, whereas in the rostral nasal passage, it seems like it's a little bit non-uniform. And I believe that that's because this is probably fluid silhouetting partially with the soft tissue nasal turbinates. Remember, up in the rostral nasal passages, fluid can silhouette with the soft tissue turbinates. However, when we get to the mid and caudal nasal passage, not only do I see this soft tissue opacity, but I also see that the majority of the osseous structures we can see on the left side are absent. And remember, when we're in the mid and caudal nasal passage, that means that there is actually true lysis going on. So there's lysis in the area of this soft tissue opacity, which is most likely a soft tissue mass. Then there are little regions of lysis a little bit more rostrally as well. Unfortunately, I can't really see the caudal ethmoid region and the frontal sinus region because there is superimposition of the mandible that's not quite out of the way. On the lateral view that's oblique, it's going to be a little bit challenging to evaluate that nasopharynx that I always talk about having you guys evaluate. It's also going to be a little bit challenging to evaluate the nasal passages, which would be normally superimposed anyway, but now there's more artifact of positioning. However, I do see that the frontal sinus has probably true increased soft tissue opacity because this is typically a fairly lucent region. So the main findings that I see of this kind of soft tissue mass with associated regional marked lysis is going to be most consistent with destructive rhinitis. And in a patient that has this kind of mass effect with lysis and is older, this 8-year-old, our primary differential is going to be an intranasal soft tissue neoplasm. And one of the most common ones is going to be adenocarcinoma, but remember there were other epithelial and mesenchymal tumors that are possible. And ultimately, one would need a biopsy so that we know our definitive histopathologic diagnosis. Remember that destructive rhinitis caused by fungal infection typically tends to occur in younger patients, less than about 4, and it also tended to be quite cavitary, so we would see much more lucent regions of cavitation with maybe some smaller nodules. So again, primary differential in this patient is going to be a nasal tumor such as adenocarcinoma. Case number 2 is a 19-year-old saddlebred gelding who is presenting with unilateral nasal discharge. I have 2 views. I have a right lateral view and a dorsal ventral view, and this right lateral view is displayed in the manner in which we obtained it. as is the dorsal ventral view. So typically with the horses, I do like to put their noses down at the bottom of the image, versus with the dogs and cats, I like to put their noses at the top of the image. When I evaluate this patient, the first finding that I notice is that there is soft tissue opacity, fluid opacity, superimposed over some of the regions of the sinuses. This is our maxillary sinus, and notice I see a fluid line in that maxillary sinus. This would be the rostral compartment that has increased fluid opacity, and then this would be the caudal compartment that actually has the fluid line. There's an additional fluid line here in the region of the conchofrontal sinus. So just the frontal sinus is here, and then there's also that dorsal conchal portion that kind of is communicating. So there are fluid lines in two of the sinuses. When we look at the dorsal ventral view, it looks like this is going to be predominantly right-sided, and the history of unilateral would go along with it being one-sided. So the maxillary sinus on the right side has quite a bit of fluid, and the right nasal passage is maybe a little bit more fluid opacity than the normal left side. There's one small additional finding that I identify, and that is that there is this kind of more focal, round, soft tissue opacity in the caudal nasal passage on the right, a little bit in the ethmoid region. Ideally, we would have an oblique view of the kind of right nasal passages, which I don't have. But we definitely have signs of sinusitis, so more than one sinus. It is right-sided. And then we have this soft tissue kind of mass-like lesion in the right caudal nasal passage. And so I would have as my conclusions sinusitis, potentially secondary to this mass, and then differentials for this mass would include a neoplastic mass, potentially. This is an older patient. Maybe an ethmoid hematoma, although those tended to be in younger patients. A nasal or paranasal cyst is another possibility. Again, those oftentimes tend to be in younger patients. And then maybe this could even be a granuloma. And we wouldn't be able to make that definitive diagnosis without additional diagnostics, so maybe rhinoscopy, endoscopy of the nasal passages, and hopefully a biopsy of that structure. Case number 3 is a 2-year-old neutered male domestic short-hair cat. This patient is presenting with respiratory neins and Horner syndrome. We have 2 views of the skull, a lateral view, and then this is that rostrocaudal open mouth view that is for evaluation of the tympanic bulla. So why don't we start with this view, because we have things that are not superimposed. We can compare left to right. And when I look at this view, here is the region of the left bulla, here is the region of the right bulla, and then the petrous portion of the temporal bone. The left bulla looks relatively air-filled. Obviously, there's some superimposition with other structures. And the wall looks thin. Remember, the cat has 2 compartments, a medial and lateral compartment. When we compare that to the right side, this right bulla contains soft tissue or fluid opacity. And then the petrous portion of the temporal bone on the right side is more opaque or sclerotic compared to the left side. So it looks like there is some right-sided bulla disease. On the lateral view, those bullae are going to be superimposed right and left, so it's going to be challenging to compare them, although this one does look like it has fluid opacity in it. But one important finding that I notice is that in this nasopharynx here, there is this focal, round, soft tissue mass that is actually eventually displacing a portion of the soft palate. So these findings are of a mass in the nasopharynx with right-sided otitis media. And in this young of a cat, this mass is almost certainly a nasopharyngeal polyp leading to that otitis media. Unlikely, but still possible, this could maybe be some sort of a granuloma that could be from an infection like Cryptococcus as a possibility. But I think that's highly unlikely, and so we will biopsy that and treat that most likely as a nasopharyngeal polyp. Case number 4 is an 11-year-old thoroughbred gelding that is presenting for nasal discharge. And we have just two views for us to evaluate. So this is our dorsal ventral view. And then this is a lateral oblique view. It's labeled with an L. So we're looking at the left nasal passages and left maxillary arcade. And then there's some superimposition of the right maxillary arcade and the mandibular arcades. Let's just start with this dorsal ventral view. When I look for symmetry or lack thereof, I see that on the left side there seems to be quite a bit of soft tissue opacity or fluid opacity that is in the left maxillary sinus kind of diffusely, as well as the left kind of nasal passage here. Compare that to the right side that is normal. There's some superimposition of soft tissues, but the maxillary sinus is pretty still loosened from air, and then the right nasal passage is less opaque as well. Looking at this dorsal ventral view, there's a little bit of a change near this tooth that I'm not sure if that's real. So what I'm going to do, these are our maxillary teeth, is we're going to look at those teeth on our oblique view over here. So here are the second, third, and fourth premolars, and then the first, second, and third molars. When I look at these teeth, I do see some changes here with this first maxillary molar. This would also be known as tooth 209. When we look at the kind of periapical region, there's increased bone opacity. There's also a very small amount of fluid with a fluid line in that rostral compartment of the maxillary sinus. So increased soft tissue fluid opacity as well as sclerosis. And then surrounding the roots of this tooth is some periapical lucency, some widening of the periodontal space. And then if you look at these roots, they have kind of an abnormal shape compared to the other teeth, so they seem to be blunted and malformed. And then one additional finding I see is that when I look at the entire tooth, looks like there is a fracture, at least of part of the crown here. So compare that occlusive surface to the other teeth. This tooth in general seems a little bit less opaque, so there could even be more fracture than just that crown. So my conclusion based on these findings is that this patient has left-sided kind of sinusitis and nasal disease. That's the discharge, and it is secondary to this fractured tooth 209 with a tooth root abscess. And so these were the findings that we had seen of tooth root abscess. The last case I have to go through with you is a 9-year-old neutered male Labrador retriever who is presenting with a painful swelling on his head. This is the only radiograph that was obtained at the outside veterinary facility. I doubt that this patient was under any sort of injectable anesthesia. There certainly is not an endotracheal tube in here. It looks like they are holding him down with a lead glove, which remember that this is not appropriate radiation safety because oftentimes the arm is actually in here, so that's in the primary beam. So we need to keep the lead out of the primary beam. So it's possible that he had a little bit of sedation, but I'm not sure if he did or not. So this lateral view is actually rotated. You can see the mandibles are not superimposed, and the maxillary and mandibular teeth are not superimposed. But it looks like they have attempted to obtain an oblique or tangential view where this painful swelling is. And so my findings are that I do see soft tissue swelling here along kind of the parietal bone, maybe just caudal to the frontal sinus and frontal bone. Then when I look in the region of the irregular soft tissue swelling, especially at the osseous structures, I'm hoping that you can see that there is this very poorly defined, almost geographic area of lysis, but then there is some moth-eaten lysis in other portions of the parietal bone. The parietal bone itself appears like it is thicker and maybe more sclerotic in some regions around that area of lysis. In fact, some of this is probably some thickening of the parietal bone kind of almost into the area of the frontal sinus. And then additionally, I see this region of somewhat spiculated periosteal reaction, as well as maybe some amorphous periosteal reaction. So my conclusion is that this patient has an aggressive lesion, so lots of signs of the aggressive nature, the kind of poorly defined and moth-eaten lysis, the spiculated and amorphous periosteal reaction, and like I said, the poor definition is kind of that poor transition zone. So a lot of findings of an aggressive lesion affecting this parietal bone, and then with this soft tissue swelling. And so my conclusion would be that the differentials for this aggressive lesion would be a neoplastic process, so that's my primary differential, and the neoplasms might be a primary osseous tumor, so this could be an osteosarcoma or chondrosarcoma affecting the skull bones. But the other possibility would be that this could be a soft tissue neoplasm, like a squamous cell carcinoma or some undifferentiated sarcoma that has secondary osseous involvement. I think it is highly unlikely that this is some sort of fungal osteomyelitis, but ultimately, as we know with most radiographic findings, we can never be conclusive on the underlying pathology, and so we would need to get a biopsy. So that concludes the cases that I want to go through with you. And again, I just really strongly recommend that you spend some time looking at examples of these different types of skull disorders in the 2 textbooks you have, as well as perusing that link to the veterinary radiology website, where you could go through the musculoskeletal cases and look for additional skull cases for your experience and practice.